Hello, and a very good evening to all. I, Dr. Disha Dalal, lecturer at Shree Swaminarayan Physiotherapy College, welcome you all on behalf of SSPC. We are thankful to our principal, Dr. Idrish Contractor, for this knowledge-enhancing webinar series. Today we have with us Dr. Dhruv Dave sir. Dhruv sir is a Master of Physiotherapy and Rehabilitation. He has done his BPT and MPT both from Government Physiotherapy College, Ahmedabad, with gold medal. And he carries with him a profound experience of more than 10 years as an academician. He completed his PhD under the able guidance of Dr. Ali Irani sir. And currently he is working at Charusat University, Changa as an assistant professor. So now I would like to invite Dr. Dhruv sir to take up the session. Over to you, sir.
Thank you, madam. It's been a great privilege for me to have the webinar session. First of all, I would like to thank Dr. Idris Contractor sir and the team of Sri Swaminarayan Physiotherapy College, Ranip, for giving me the opportunity to have webinar and talk on physiotherapy in non-communicable disease. Is it visible, madam?
Yes.
Okay. Yeah. Yeah. So physiotherapy for non-communicable disease is when we would like to talk about. First of all, we will go through how the flow of presentation is going to be. The contents of the webinar is we will talk about what is non-communicable disease. Then we will go into each of the non-communicable disease in detail, likewise cardiovascular disease, type 2 diabetes mellitus, cancer, and chronic respiratory diseases, right? So prior to starting about the non-communicable disease, why we want to be in concern about the non-communicable disease? Because the non-communicable disease is important to us, because it is not only just the COVID-19 era is going on and is ultimately having others to be part of the communicable disease, but along with that, if we are talking about global burden of disease, GBD, and if we are looking at out of 10, 6 of those global burden of disease is from the non-communicable disease. And that is the reason why seriousness about the non-communicable disease is important. Now, when we are talking about why physiotherapist and the physiotherapy student, so when my friends and the participants there on the Facebook, if we are talking about, I would like to say that when we pass out our Bachelor of Physiotherapy or even Master of Physiotherapy, few of the opportunities which are going to come to us are, number one, we can have our own clinic, and another one is that we can have the home visits, and by that we can earn money, fame, and lot of other things. Now, when we are talking about the non-communicable disease, may it be cardiovascular disease, diabetes, chronic respiratory disease, or cancer, why one should listen this carefully is because by dealing with this type of patients, we can earn money. Now, when the money matters, people are going to have their raised ears. They are going to listen this very carefully, because at the end of the day, whether it is you, me, or anyone up there in the world, are concerned about money. And when that money is what going to be linked with the webinar, it's going to be very helpful. So from once you are finishing your Bachelor of Physiotherapy, and once you are start dealing with the clients, patients, many of them are going to suffer from non-communicable diseases. And then when we are going into the detail of webinar, we will look into the detail about the epidemiology and few other factors. First and foremost thing which I would like to say, that this is one of the small WhatsApp message I have just received, that જિંદગીની દોડમાં એટલા બધા આપણે આગળ નીકળી ગયા અને બાકી બધા આપણાથી પાછળ રહી ગયા, પણ એકમાત્ર એકલું પેટ છે જે આગળ નીકળી ગયું. And that's where it's what the obesity, and along with the obesity, few other lifestyle related diseases have come into the body, into our life, and make our life miserable. Another one, पैसा आएगा चला जाएगा, खुशियां भी आएगी और चली जाएगी, पर एक सिर्फ मोटापा ही सच्चा दोस्त है जो आकर कभी जल्दी नहीं जाता. Most of our clients are having this kind of problem and complain to us that sir, मोटे तो हो जाते हैं पर फिर ये मोटापा है वो जल्दी से जाता नहीं है. And correct me if I'm wrong, that as the age advances, may it be a male or female, over a period of 30-35 years, gradually the mental satiety comes, and along with mental satiety the physical satiety also comes. And then as what in the previous slide, it's what for the male around the abdomen, and for females around the hips, it starts expanding. And that's where I say to many of my friends, expanding the horizons, right? Okay, coming to the main part, what's non-communicable disease? So non-communicable naturally suggests us that it is a non-infectious disease. It doesn't spread from person to person like wise the COVID-19 situation. It also lasts for a long period of time, and it is also known as maybe chronic disease or lifestyle disease. And then there are factors that's going to affect, like genetic, physiological, environmental, and whatnot, for causing this disease. So we'll go into the detail of it. Now, when we are talking about the cardiovascular disease, there are the risk factors, and the risk factors, we can stratify it into non-modifiable and modifiable risk factors. Now, non-modifiable risk factors mean by that your birth and birth date is not under your control. That's what the given God gift. And as you grow, that age also is going to grow. So that age is a non-modifiable risk factor if we are talking about cardiovascular disease. Same way, if we are talking about family history. Now, family history here, I mean by that the first first persons of the family, if they have the history of cardiovascular disease, coronary artery disease, or myocardial infarction, or ischemic heart disease. Likewise, if father or mother or the siblings, they do have the history at the early age before 65 years, then that is to be considered as family history positive, and which again is a kind of risk factor, not modifiable. You cannot have the control over that. But if we are talking about other risk factors like cigarette smoking, we go for movies, and prior to starting movie, we do have a small advertisement where it's what making us aware about usage of tobacco, cigarette, and likewise, धूम्रपान padega महंगा. So it is necessary that one should quit smoking. Sedentary lifestyle. The way the COVID-19 situation is, has produced sedentary lifestyle amongst us. And that's the reason why, likewise, smoking, it's what being said that sitting is the next smoking. So it is very much necessary that one should move and move the body, right? For sedentary lifestyle is again a modifiable risk factor, same as that of obesity. Obesity, when we are talking about, we are talking about the BMI. And again, for us, because we are talking about Indian and Asian context, so our BMI ranges are slightly lower compared to that of the global population. And that's the reason why 23.9 is what is our concern when we are talking about Indian and Asian context. If we are defining overweight, obesity, class 1, class 2, class 3, and likewise. Another risk factor is hypertension. Hypertension, now every now and then people talking about that they do have stress, pressure, tension, and that's how it's what is causing a lot of problem. Pressure, कहीं किसी ने कुछ बोल दिया, कहीं किसी ने डांट लिया, कहीं कुछ बताना था नहीं बता सके, अपने अंदर रखा, and that ultimately evolves into the increase in the blood pressure and causing hypertension in the body, which I am going and talking into the detail when we go into the few next slides. Dyslipidemia, when I am talking about dyslipidemia, is again another concern where the lipid levels up there in the body, if we are talking about low density lipoprotein or total cholesterol and likewise, these all are ultimately having their values higher and causing the problems. Again, if we start doing exercise, these readings we can improvise upon, and again that comes under the modifiable risk factors. Diabetes, again, I love and always like to talk about diabetes, and we do have that in great depth when we are talking about diabetes in detail. HDL I have put as negative risk factor. Here we mean by that high density lipoprotein, more it is, it's going to be good. So the lower value of high density lipoprotein is to be considered as the risk factor, right? So that's how I have put the word negative risk factor. Now, when we are talking about the two, that is type 2 diabetes mellitus, it is interrelated with the hypertension, is interrelated with obesity. So इसमें क्या होगा that अगर कोई आदमी मोटा हो गया, उसको मोटापा है, so then that individual is going to suffer from hypertension and diabetes eventually. Or if someone who is suffering from diabetes will ultimately have macrovascular and microvascular changes and will ultimately result into hypertension, that is high blood pressure, and obesity, that's what increase in the BMI values, increase in the weight compared to the height of the individual, increase in the circumference around waist, increase in the ratio of waist to that of height, and likewise. So That's where the diabetes is causing the issues and problem to that of obesity as well as hypertension. So these three are quite interconnected and correlated. Now, when as what I've said, that first and foremost thing which I would like to talk about, that in this photograph, it's what is suggesting about that each and every different individual, when being measured, had a different blood pressure altogether. The issue was that someone who has blood pressure had the heart attack problem, and someone who has the issues with that of the heart attack will have the problem with that of the blood pressure. So again, it is quite interconnected. Now, when I am talking about hypertension, what do we understand by hypertension? So if systolic blood pressure of someone is showing on the sphygmomanometer of mercury 140 plus, then that is to be considered as high blood pressure. Or if diastolic blood pressure more than or equal to 90 millimeter of mercury, then that is to be considered as high blood pressure, and we put that individual into the hypertension category. Now, when we are going through the JNC 7 classification up there on 2003, those who are between 120 to 139 on their systolic, they are to be said as prehypertensive, or 80 to 89 on diastolic, they are prehypertensive. The high blood pressure stage 1 is between 140 to 160. Stage 2 would be 160 or higher. The hypertensive crisis is what is the emergency situation and where one need to act very promptly. Similarly, diastolic blood pressure is another and major concern so far as concerned with the chronic heart disease, or if we are talking about stroke or any of the other major events so far as concerned with kidneys, peripheral vascular disease, and likewise. So diastolic blood pressure is a major concern. If someone is going to give us the choice that which one would you like to have more, then one should opt for systolic than that of the diastolic, because diastolic increase will have a greater impact on the systems together, and likewise that we will see into the few of the other slides. Now, when I'm going to talk about the epidemiology, why it is important, as what I have said, that this is what is correlated for all our physiotherapy to earn money. And if we want to earn money, we need to know about the seriousness of the global burden of disease, and one of them is what is cardiovascular disease, the number one cause of the problems in relation to global burden of disease. Overall, 1 out of 5 individual is suffering from hypertension. That's what 20%. And this is what is dramatically increasing if our clients or patients are above the 60 years of age. So as the age advances, naturally the peripheral vascular resistance increases, and those are going to have the effect on heart along with the wear and tear. That's what bound to happen with the body. In many of the countries, if we are looking at those data, 50% of the individual in this age group have the hypertension, right? So, and we are talking about 60 and above, half of them are having hypertension. And if again we are looking and talking in surround our neighborhood, very quickly and easily people are using the word that, okay, I am suffering from high blood pressure, hypertension, I am suffering from diabetes, and likewise. So that's very routine in and around our neighborhood. Now, when I'm talking about the next slide, which is what is suggesting us about the forecasting of how the prevalence of hypertension which is going to increase. So if I'm talking about in 2000, it's what just the 639 million of individual. From that, it's what has shooted up and going to shoot again and again to 1.15 billion. So that's a steep rise in of 60% so far as concerned with the prevalence of hypertension. Now, when we are going to talk about the things about treatment aspect, that how many of us are knowing about hypertension? That's what is about awareness. The next important aspect is what is treatment part. And the next important aspect which we want to see is about the control. How many of them are able to control? So if we are looking at this particular graph, the graph is going to suggest us that from 1970s to that of up there in 2000 and in early 21st century, the gradual rise has happened over a period of time so far as concerned with the awareness, and same way that of with the treatment and even with the control of hypertension. Control of hypertension here I mean by that someone is what able to limit them as a hypertension. So this is again very important so far as concerned with the aspect of hypertension. Now, if we are looking and talking about Indian context, so about 40% of our population is what is suffering from hypertension. In the United States and in other countries, this is increasing. But when we are talking about again in this graph, which again is very important, where it is what showing us the detail about the hypertension and diabetes, hypertension and heart disease, hypertension and cancer and hypertension. This is what in a nutshell about 45 years to 64 years, that is in young age group. And as the individual become elderly in the geriatric age group, this again has exponentially increased over a period of time. So it's very important that we take the non-communicable disease very seriously, right? Now, moving on to the next one, the age-wise distribution. So age-wise distribution, again, as the age advances, the clients are what bound to have the hypertension. And that's what is our area of concern, right? Now, if we are talking about gender-wise distribution, as the age advances, the males and females, they both are what going to have their concerns and consideration, and they both move together, and all of them are going to have the hypertension over a period of time. So that's where our concern is. Now, when we are talking about hypertension and obesity, if we are, and that's where I was talking about is BMI, and if our BMI falls within normal limits, that's what between 18.5 to 23.9 according to the Asian population data, then we do have chances of getting hypertension about 1/3. As our weight increases, and if we move beyond 23.9, according to the overweight, obesity grade 1 and grade 2, 3, our prevalence of getting ourselves hypertension increases, and it increases from 34 to 60 to again about 1.8 times it has increased, and here it doubles. So along with hypertension, one need to take a good care about weight. If we are talking about hypertension and diabetes, so it's what in male the prevalence is 35 and in females it's 46%. Now hypertension and its association with smoking, which is very known, significant trends of increasing prevalence of hypertension as the individual smokes. And when we are talking about smoking, it's about smoking of cigarettes packets per years, and it ultimately not only land up with cardiovascular disease but lung cancer and many more things. So that's the reason why the smoking is one of the risk factor, but it is modifiable risk factor. Now, when we are talking about Indian context, so it's what the urban has an upper hand over the rural when we are talking about hypertension, because naturally the kind of environmental factors that's going to affect to the urban community and likewise is quite different and much more. And that's the reason why urban have about 48.2%, while that of the rural has less than 1/3. That's about 31.5%. Awareness naturally towards finding early about pre-hypertension and hypertension is 1/4, and to that of the urban, if we are talking about Indian population, it's about more than a half. This is the kind of study that they have done in Human Hypertension Journal. Now about pre-hypertension and the study that has been done in Delhi, they have found that about 16% of them have self-reported hypertension, and about 26% are undetected hypertension, and they are suffering from and they do not know. And 1/3 of them are in the pre-hypertension range between 120 to 140. Now, this is what a kind of data, and where again I want to emphasize over about the Gujarat, right? And here I want to emphasize that the Gujarat is showing a kind of great mark so far as concerning the 40% of the individual in pre-hypertensive range, while 27% are non-hypertensive individual and 18% are newly diagnosed hypertensive individuals. These are what about the few of the metros we are talking about. Now, when the line graph is what being made, you can see very well that the cities like Jaipur and Delhi are coming up, and again in them the issues are there with the women more compared to that of the male individual men, right? Even in children, you just imagine that they do have the issues with the overweight. And one of my colleague, she has done her study on the effect of weight and its at school children and its significance on academic performance. So academic performance also is affected by weight of the kids, and that is what is one of the in thing as of now. And people are worried and concerned about weight of the kids, because the weight of the kids more, and that ultimately causes the issues and problems. Now, from hypertension to sugar diabetes, if I am saying, then about this particular slide is suggesting that pancreas is what is lying down in the sofa, and on a lighter note saying that I am not ill, but then my pancreas is at ease, is lazy, and that's the reason why it's not able to either produce insulin, or if it is what able to produce insulin, then the body is not able to sense it, right? That is what is happening with the type 2 diabetes, the insulin resistance we are talking about. Now here, in relation to that, the International Diabetes Federation have come down with the data, and in Southeast Asia, if you are looking at 11.3% of the population is what is suffering from type 2 diabetes, and if we are talking about Indian context, 1 in every 11 adults are what suffering from diabetes. And you and me, we all know that how the diabetes is affecting the body. It is to be called as a termite in the body. Someone who is diabetic for the initial few years period of life, not able to know that they are suffering from diabetes, and like termite, it is what is affecting the furniture or wood, and likewise similar way the diabetes is what is affecting the body. It is affecting at macro level as well as micro level, and ultimately causes a problem in the body. If you name the system and it affects, if it is heart, it produces atherosclerosis, myocardial infarction, heart attack, ischemic heart disease, and whatnot. If you're talking about kidney, it produces nephropathy. If you are talking about peripheral vessels, it causes peripheral vascular disease, amputation. If you are talking about nerves, it produces diabetic neuropathy. If you are talking about eyes, it produces retinopathy. If you are talking about brain, it causes stroke and whatnot. And that's the reason why I'm saying that impact of diabetes is too much. 1 in 6 adults, right, is coming as a diabetic from India. So India is a diabetes capital, and for India, Ahmedabad is what is a diabetes capital. Why Ahmedabad is diabetes capital is because we love and like sweet very much. We love and like sweet very much, especially the Gujarati, the typical Gujarati, they have the adding of sugar और जैगरी, जिसे गुड़ हिंदी में बोलते हैं, वो कुछ ना कुछ खाने में वो अचूक रखते हैं, वो कहीं ना कहीं मिला ही देते हैं, चाहे वो सब्जी बनाते हो, चाहे वो दाल बनाते हो या कुछ भी बनाते हो, वो हमेशा चीनी, शुगर या गुड़, जैगरी का इस्तेमाल करते रहते हैं. So that's the reason why the whole Gujarat is very prone, and especially again the Ahmedabadi people, we are fond of sweet and fried foods, and that's the reason why we are prone to develop diabetes much more compared to the other counterparts of the globe. Now, when it is coming to the diagnosis part of diabetes, it is very important that we should know about the Indian Council of Medical Research ICMR guidelines, which suggests that if the value of the blood sugar is beyond a certain, then we need to stamp them as diabetes. Okay. Prior to that, I forgot to say for hypertension as well as for diabetes, to stamp anyone that someone is suffering from hypertension or someone is suffering from diabetes, the similar values of either blood pressure or that of the sugar to be taken for the consecutive 3 days, and then if it still comes, then we may need to stamp them. Another beautiful thing about diabetes is that we do have this HbA1c with us. And what is HbA1c? The HbA1c is what is the average blood sugar value over a period of 3 months. Now, when we are talking about management of diabetes, it is about not only just the diet or change in lifestyle, but exercise and medication. And I know that all of us are interested about what kind of exercise one should do. Should I do yoga? Should I do aerobic exercise? Should I use dumbbells? Should I use TheraBands? Or what should I do so that I can control my sugar level? I can manage my diabetes and likewise. So if we are looking at the systematic review that's available for the various types of exercise for diabetes, the routine frequency, what we have found out that between 1 to 7 sessions per week, one can do aerobic exercise. If we are talking about the intensity of exercise, and this part is very important so far as concerned the final year Bachelor of Physiotherapy students or for the postgraduate students, that when you are going to design the protocols of exercise, and that's where you are going to be master of your prescription. The prescription of exercise is very important. As the physician prescribes the medicine, the physiotherapist prescribes the exercise. And as your prescription precise as possible, that's how the adherence to exercise, the improvement in patient, and few other things are what bound to happen. And that's why my teachers used to teach me that, Dhruv, you need to be good in terms of prescribing the exercise. So, okay, I was talking about intensity of exercise, and intensity of exercise could be measured by VO2 max or VO2 peak, or in case if we do not have those formulas and things available, complexity may not be there, then for our client or patient population, we need to make them understand about heart rate monitoring. Or nowadays, even the Fitbit things are available. People are using it to measure their pulse rate, and that's how one can control the intensity of exercise. When we are talking about duration of exercise, the duration of exercise could be between 40 to 75 minutes, and the total duration which is what about to produce some kind of results between 2 months and a year. So again, why I am varying this grade is because of the kind of systemic review available. It suggests that the results are bound to be produced, and again it depends from individual to individual, and that's why when you start prescribing exercise, it need to be tailor-made. When someone who is talking about resisted exercise, as what I've said, that someone would like to do it with dumbbells, someone would like to use barbells, someone would like to have bench press, leg press, and likewise. So for them, or even TheraBand, TheraTube, and likewise, so one can have the frequency of 2 to 3 times per week. The intensity of exercise would be 1 repetition with 50 to 80% maximum, and the duration again would be 40 to 60 minutes between 8 weeks to 6 months. So this again is what is the result of systemic reviews. Now, what are the type of exercise, which is again one of the major concern when we are talking about that, when we are saying to our clients that someone should do aerobic exercise or someone should do progressive resisted exercise or other form of exercise, then what they should do. So in relation to aerobic exercise, one should do cycling or swimming, or can run on treadmill, can even do skipping ropes, being homebound, even cross trainer in gym, arm ergometer, using the upper body, upper torso, jogging. So all sorts of things are to be included in aerobic exercise. So moving to the previous slide, I mean by that someone to whom we are prescribing the aerobic exercise, this many options are available to them. So out of them, we can put them to few of them or all of them, depend on the kind of availability, whether they are going to be at home, you are seeing them in your home visits, or they are going to come to your clinic and the kind of equipments you do have, or they are going to gym and you are there as a fitness expert. So depend on that, you can include the type of aerobic exercise. When we are talking about progressive resisted exercise, it's what the major group of muscles of upper limb, trunk, and lower limb, and that could be trained with weights, therabands, therapeutic. Naturally, the kind of question which is what bound to come in your mind, that which muscles, what exercise, and likewise. So if once we are going to the next slide, I will elaborate about the muscles and the exercise as well. The other form of exercise, like one can do yoga. We just had celebrated yoga on last Sunday, and yoga can be part of exercise, whether someone who is talking about hypertension or diabetes or many other lifestyle disease or non-communicable disease. Yoga has its own significance for non-communicable disease. Same way Tai Chi, the form of exercise which is what being followed in the eastern part of the world. Now this is what the kind of dosimetry which I am talking about. If I want to prescribe the aerobic exercise for the particular individual suffering from diabetes with HbA1c values about 8.2, then what kind of dosage I would like to prescribe about the aerobic exercise. So I will start with the warm up and cool down exercise for 3 minutes each, where they are going to do stretching exercise of quadriceps or hamstring, calf, biceps, triceps, back, and with each of the muscle group that needs to be stretched twice. So that's what going to warm your body up. And you may do a 5 minutes of cycling. So that's how your body is warmed up. And then next is what you need to do your aerobic exercise, where you may include upright bicycle. Someone is doing bicycle for about 10 minutes, then a rest in between, where someone should come back to the rate of perceived exertion back, and then again to 20 minutes of treadmill, and then again back. At every point in time in between the two exercise, the rest is to be given, but rest should not be to that great extent so that again patient is coming to the basal level, and then again you need to do warm up and then doing exercise. So it's what is that slightly if the rate of perceived exertion reaches to 13, 14, then from there again give rest, reach it again to the level of 10, and then again you restart with the things for 20 minutes of treadmill and 20 minutes of elliptical with a rest in between, right? So I have written the word that treadmill or stationary upright bicycle cross trainer is helpful. Now that's for the first 3 days. So this would be possible to do it on Monday, Wednesday, and Friday. For the another 3 days, it could be the resisted exercise, where again the warm up and cool down remain same, but then when you are going to do about 10 repetition for each of the 9 resistive exercise, and that is what you are about to do. Seated leg press, you are going to do straight leg raise with the weight, you are going to do hamstring curls with the weight, you are going to do biceps curls, triceps curls, lateral raise for shoulder, front raise for shoulder, same way for hip abduction and hip extension. So when you do this in a circuit training with a rest in between, that circuit interval training, you are in a position to finish it off within 30 minutes period of time. So it's what is overall your 40 minutes of resisted exercise you need in a position for exercise like weights, free weights you are in need of, or you are going to be in need of with different types and colors of therabands, and the kind of muscles you are going to target I have mentioned down over here. Now from diabetes, if I'm going to talk for the last few slides about global cancer and its data, the global cancer is what is increasing, and you are in a position to look at the Asian numbers, that we are about 50% so far as concerned with the cancer. When we are talking about the cancer, the major concern here is what is about tobacco, physical inactivity where we can work upon, overweight again we can work upon. It's about the low fruit and vegetable intake, and low vitamin D is what bound to be there with the foreign population. So our concern would be physical inactivity, alcohol, and the low fruit and vegetables availability, right? So it's about smoking, it's about the UV rays and the vitamin D, it's about alcoholism, it's about weight control, it's about inactivity, and it's about the food habits, which is ultimately causing the cancer. Now I have specifically designed a kind of protocol if we are talking about the home-based exercise, and this is the home-based exercise. Mainly our concern would be the patients of breast carcinoma. So what kind of home protocol we can have. So the kind of slide I am about to I have shown down over here is showing us that this kind of materials, pamphlets, are necessary for our client population, where not only just we are showing them exercise, but along with that we are giving these handouts to them so that they can take along with them, they can keep it with them, and as and when if they are going to forget, they are going to look at the pamphlet and can perform the exercise. This exercise are going to be major in relation to that of the upper extremity, and because the upper extremity exercise is necessary when we are talking about mastectomy, radical mastectomy, modified radical mastectomy, and likewise. Again, in cancer, the major concern is what I have said, and one of the study we have done about a few months back, and we have found our result that about if someone who is very familiar with the SPADI, that's what the disability index available for the shoulder clients, and this particular outcome measure is what is showing a significant amount of improvement so far as concerned with the home-based exercise. That is in the initial at just at the beginning on post-operative day 1, the SPADI is what is the same, but as the days passes and in compared to the control group with the usual care, the SPADI remains more, as the one who is following the exercise has quite less SPADI score. SPADI, if for the individuals, those who do not know, is showing the disability index, and in which more the score, more the disability. So the lesser score is what is showing the good result. Last few slides, when I am talking about chronic respiratory disease, I mean by that it's about asthma, it's about chronic obstructive pulmonary disease, chronic bronchitis, emphysema, lung cancer, cystic fibrosis, pneumonia, pleural effusion, and whatnot. And these all diseases are ultimately the non-communicable disease, and being there, it causes a great burden to the individual, If we are talking about financial things, it's the burden to the family, society, and nation at a large. And that is the reason why we need to address, time and again I am saying, about all these non-communicable diseases. These non-communicable diseases are very important and increasing. And if we're talking about respiratory disease, the kind of role available to us is that we can ask them to have breathing exercise. Along with that, now it's Anulom Vilom, Kapalbhati, Pranayam. All this is what is possible for improvising them. Along with that, autogenic drainage, active cycle of breathing technique, a few techniques of PNF in respirations for those bed-bound clients. Functional training is very important if we are talking about the non-communicable disease, and especially in the chronic respiratory disease, because the individual should go and reach back to the level where he or she is participating. So participation restriction need to be improved, and that's where the functional training role is very important. Cough facilitation techniques are again helpful, and removing the secretions and ultimately making the individual better in terms of rate of perceived exertion and a few others symptoms so far as concerned with the chronic respiratory disease. So that is what in nutshell what I have covered about the physiotherapy in non-communicable disease. And now I would like to have the kind of questions if we do have across from the participants, and I would love and like to address those questions, because whatever the webinar we do, the main gist and concern is of the webinar is to have the interactive sessions, to have the questions and answer them, and likewise. So I would like to have those questions. Yes, if we do have. Yes, ma'am. I'm stopping my slide share. This presentation I am going to share it with principal sir, and then sir can share it with others. So that's the kind of thing from my side.
Hello.
Yes, yes, ma'am.
We don't have any questions right now.
Okay.
So on behalf of SSPC, I would like to thank you, Dr. Dhruv Dave, sir, for sharing your valuable time and knowledge with us. So thank you so much, sir. It is really informative session. So once again, thank you so much to the all participants for the joining this webinar.
Thank you, ma'am. Thanks a lot.
Good evening and take care.
Yeah, thank you, ma'am. Have a nice time. Thank you, Idris sir. Thank you, the whole Shree Swaminarayan Physiotherapy College staff, for providing the opportunity. Special thanks to my faculty, Dr. Ratan Kuman sir. He has helped and assisted us for making this event live on Facebook. So thanks from bottom of my heart to Ratan sir for handling the technical things. I hope the things are gone without any kind of technical glitches. So thanks to Ratan sir. Thanks again to Idris sir and Swamiji of Shree Swaminarayan Physiotherapy College, and Siddhi madam and Disha madam. The way they were part of, they were behind me from about 3-4 days, that what kind of technical things one should have, and likewise, and ultimately I am only the individual who is able to deliver it, but then there are many others who are behind me, worked behind curtains, and I need to give them enough credits for this webinar. Thank you. Thanks a lot.